In this next lecture, we're going to discuss two unrelated, but both very commonly tested topics on step 2. The first being sarcoidosis, and the second being pulmonary thromboembolism. Firstly, sarcoidosis is a disease that's actually most common in African American women. It's an idiopathic inflammatory disorder, predominantly of the lungs, but can affect pretty much any organ system in the body. It's characterized by infiltration of non-caseating granulomas. That's the key to identifying sarcoidosis. The clinical presentation often includes a young African American woman with shortness of breath on exertion and occasional fine rales on lung exam. There is usually not evidence of wheezing that is seen with asthma. Other less common presentations may include erythema nodosum, painful tender nodules on both of the patient's shins. Sometimes patients will present with lymphadenopathy. This is either on examination or often seen as bilateral hilar adenopathy on the chest x-ray. This is going to help you out with a diagnosis question. Other common presentations for a patient with sarcoidosis would include constitutional symptoms such as fever, malaise, or weight loss, arthritis, parotid gland enlargement, facial palsies such as a Bell's palsy, heart block or even restrictive cardiomyopathy, CNS involvement, or iritis and uveitis. Every one of these presentations includes infiltration of non-caseating granulomas into various organ systems. For example, with regard to the heart, you can imagine that if there's something infiltrating the cardiac tissue, such as these granulomas, if the electrical system gets infiltrated, you're going to have arrhythmias, such as heart block. And if it infiltrates the actual myocardium of the heart to a certain point, you can develop a very stiff heart and restrictive cardiomyopathy. To go over some of the other organ systems in more detail, let's take a look at this diagram. The patient with sarcoidosis can have some brain complications, again, from infiltration of the neurologic tissue with sarcoidosis. Eye problems, including burning, itching, or tearing, can often occur if the patient has uveitis. The salivary glands can also be infiltrated, as can lymph nodes in both the neck and chest. As we said, this is most commonly bilateral hilar lymphadenopathy seen on the chest x-ray. Complications in the heart, as we've said, heart block and restrictive cardiomyopathy. You can often have granulomas throughout the body, but especially in the lungs, liver enlargement, spleen enlargement, and sometimes erythema nodosum, this itchy and painful rash on the lower legs and ankles. Lupus pernio can also occur, which is painful skin sores on the face. And don't be confused about the name. Lupus pernio is a face rash related to sarcoidosis and has nothing to do with SLE, or systemic lupus erythematosus. Patients can develop skin lesions pretty much anywhere, most commonly on the back, arms, neck, face, and scalp. And as we've said, enlarged lymph nodes in the chest near the windpipe and lungs, as well as scarring granulomas throughout the lung parenchyma are the most common in this disorder. One tip for step 2 is that you should answer sarcoidosis as the correct answer when you have a chest x-ray or a chest CT showing bilateral hilar adenopathy in a generally healthy African American woman. Remember, although liver and kidney granulomas are very common on autopsy, they are very rarely symptomatic in these patients. It's the lung disease, as well as cardiac manifestations, that cause the majority of the morbidity and mortality associated with sarcoid. The best initial test you should answer on step 2 for a patient with suspected sarcoidosis would be the chest x-ray. You'll see hilar lymphadenopathy in greater than 95% of patients with sarcoid. You can also see parenchymal involvement, which can be present in combination with the lymphadenopathy. Sometimes you'll see only bilateral hilar lymphadenopathy. Other patients will have this lymphadenopathy with evidence of parenchymal disease. Still others may have parenchymal disease alone. Which of these manifestations the patient has simply depends on the stage of disease. Here's an illustration of what sarcoid can look like in the lung. You do see some bilateral adenopathy here around the lung hyla, and you also see this interstitial infiltrate, particularly in the right lower lobe of the lung. The most accurate test to diagnose sarcoid is going to be a biopsy of one of the involved lymph nodes. Again, you're going to see granulomas, and they're going to be non-caseating or non-necrotizing. Some patients actually have an elevated ACE level. This is present in 60% of patients with sarcoidosis. Hypercalciuria is present in 20% of patients. Hypercalcemia in 5% of patients. This is because granulomas and sarcoidosis actually produce high levels of vitamin D. The PFTs most often show restrictive lung disease, which is characteristic of any interstitial process in the lungs. You'll see a decreased FEV1, FVC, and TLC with a normal FEV1 to FVC ratio. The management of sarcoidosis is primarily with prednisone. Steroids are the drug of choice, and very few patients fail to respond. One commonly tested point on step 2 is that an asymptomatic patient with just hilar adenopathy does not need to be treated at that time. At this point in the lecture, let's change gears over to thromboembolic disease. Pulmonary emboli and deep venous thrombosis are essentially treated as a spectrum of the very same disease, which is a blood clot. PE derives from DVT of the large vessels of the legs in about 70% of cases. The other 30% typically originate from the pelvic veins. However, the risks of both are the same, and the management is no different, so we can discuss DVTs from both locations at the same time. We often think about the etiology of thromboembolic disease as defined by Virchow's triad, which outlines the conditions that predispose to venous thromboembolism. The first of the 3 parts of the triad is stasis of blood flow. This could be immobility, secondary to perhaps a recent surgery, or a patient with poor forward flow, such as one with severe CHF. Any patient in a hypercoagulable state is going to be more prone to developing a venous thromboembolus. These could be patients with genetic predisposition, such as factor V Leiden mutation, or the presence of any malignancy, which leads to an increased risk of DVT. Lastly, any endothelial injury within the blood vessel is going to predispose to a thromboembolic event. This can include trauma, surgery, a recent fracture, or even just infection. The clinical presentation usually includes sudden onset shortness of breath, and you're going to note clear lungs both on exam and on the normal chest x-ray. In a pulmonary embolus, other findings might include tachypnea, tachycardia, cough, and less commonly, hemoptysis. If the patient had a DVT in their leg leading to the pulmonary embolus, leg pain will also be a presenting symptom. Some patients will have pleuritic chest pain, which is a result of lung infarction from the pulmonary embolism. Remember, fever can also arise from any cause of clot or hematoma throughout the body. If the embolus is extremely severe, the patient will actually have obstruction of flow and may have hypotension. Almost all questions about pulmonary embolus on step 2 are going to concern diagnostic testing and treatment. Truthfully, there is no single uncomplicated diagnostic test for a PE. Chest X-ray, EKG, and ABG are the correct answers for the best initial tests. However, none of these are extremely accurate. Remember, in PE, the main issue is to realize what's the most common finding and what's the most common abnormality when there is an abnormality. Let us help to answer this question. With regard to the chest x-ray, it's almost always normal in a PE. Most commonly, if there is an abnormality, it's just plain old atelectasis. Less commonly, a wedge-shaped infarction can be seen, which is called the Hampton hump, or you can see oligemia, or decreased blood flow and vascularization of one lobe, known as the Westermarck sign. Both are much less common than simple atelectasis. The EKG in thromboembolic disease most commonly shows sinus tachycardia. You can also see nonspecific ST wave changes. Only 5% of patients are going to actually show signs of right axis deviation, RV hypertrophy, or a new right bundle branch block. It must be a very severe pulmonary embolus to cause this kind of strain acutely on the RV. One of the initial tests is the ABG. In a patient with a PE, hypoxia will be a common finding, as well as a respiratory alkalosis, as manifested by an increase in the pH and a decrease in the arterial pressure of carbon dioxide. Again, the patient will have a normal chest x-ray. If you see a normal chest x-ray with this kind of ABG, think of PE. A frequent wrong answer on step 2 is to choose S1Q3T3 pattern as the most common abnormality on EKG. This refers to the very rarely seen combination of an S wave in lead 1, a Q wave in lead 3, and a T wave inverted in lead 3. This is sometimes seen on an EKG in a PE, but is far less common than good old sinus tachycardia. Let's pause now for a practice question. Here we have a 65-year-old with recent hip replacement presenting with acute onset shortness of breath and tachycardia. We have a normal chest x-ray and an ABG showing an increased AA gradient. The EKG shows sinus tachycardia. What is the most appropriate next step in management? Answers include IV heparin, thrombolytics, IVC filter, embolectomy, spiral CT scan, VQ scan, lower extremity Doppler studies, or a D-dimer. The correct answer is A, intravenous unfractionated heparin. This patient's history and initial labs are extremely suggestive of a PE. In this situation, it is far more important to start therapy than to wait for the results of a confirmatory test. Thrombolytics is incorrect because it's only used when the patient is hemodynamically unstable and has acute RV failure. An IVC filter is only indicated if the patient cannot tolerate anticoagulation, or if they continue to develop thromboemboli while on anticoagulation. Embolectomy is only reserved for very severe cases, and a spiral CT, VQ scan, or Dopplers are not indicated at this point in time. Remember, if the history and exam are extremely indicative of PE, you start treatment before going to a confirmatory test. Lastly, the D-dimer, while extremely sensitive, has extremely poor specificity. The spiral CT scan is often used as an accurate test for thromboembolic disease. It's also called a CT angiogram and is the standard of care in diagnostic testing to confirm the presence of a PE. Remember, you're doing this test after the initial tests of X-ray, EKG, and ABG. The specificity is quite good at 95%. However, the sensitivity is 85%, so you might actually miss up to 15% of clots with a spiral CT scan alone. Here is a chest spiral CT with radio contrast. As you see, there are multiple filling defects both at the bifurcation and in the pulmonary arteries. This CT is very classic for an acute pulmonary embolus. A different diagnostic test is the ventilation perfusion scan. In this test, the patient breathes in radio-labeled air and is given an intravenous contrast agent. Scans of the lung are then taken to compare the areas of ventilation with the areas of perfusion. If you see areas of segmental mismatch, this is indicative of a pulmonary embolus. These scans are read as either low, intermediate, or high in terms of their probability for predicting a PE. A high probability scan has no clot in 15% of cases. In other words, a false positive rate of about 15%. Low prob scans have a clot in 15%, therefore a false negative rate of about 15%. Therefore, you have to interpret the results in combination with your clinical suspicion. A high probability scan in a patient who clinically does not appear to have a DVT-PE is therefore not very helpful. However, if a patient presents with the classic signs and symptoms of a PE and then has a high probability VQ scan, you can be fairly certain that they do have a PE. Remember, a chest X-ray must be normal for a VQ scan to have any degree of accuracy. If the patient has pneumonia or some other form of underlying lung disease, the VQ scan is not going to be helpful. In that situation, you should do a spiral CT. Here's an example of an abnormal area of decreased perfusion on a VQ scan. You see the normal on the left, where everything looks to be matched. On the right, you see certain areas that, while being ventilated, are not being perfused. One other diagnostic test that shows up frequently on step 2 is the D-dimer. This is a test that is extremely sensitive for PE or DVT. It has a better than 97% negative predictive value. In other words, if you have a DVT or a PE, you almost certainly will have an elevated D-dimer level. However, the specificity is extremely poor. Any cause of clot or any cause of bleeding in the body can elevate the D-dimer level, as can a whole lot of other problems in the body. Therefore, a negative test excludes clot, while a positive test doesn't really mean anything. So, on step 2, you should remember the following. D-dimer is the correct answer when your pre-test probability of PE is low, and you need a simple, non-invasive way to exclude thromboembolic disease. This is the only situation where D-dimer is the correct answer. For a patient in whom you suspect PE, another possible test is the lower extremity Doppler study. If you suspect PE and you have a positive lower extremity Doppler study, no further testing is needed. However, remember this, only 70% of PEs originate in the legs. So, you're going to miss 30% of cases if you do a Doppler study alone. You do not need a spiral CT or VQ scan to confirm a PE if there's a clot in the legs. And again, this is because it's not going to change your therapy. The patient is going to need heparin and 6 months of warfarin regardless of whether you confirm a PE in the lungs or not. A simple algorithm to follow for step 2 is the following. If your spiral CT is negative and you still have high suspicion for a PE, you can get a VQ scan or a lower extremity Doppler. If those are negative, at that point you can feel pretty safe withholding therapy with heparin. The lower extremity Dopplers are only a good test if the VQ and spiral CT do not give clear diagnoses. One much less commonly used test today is angiography. This is the most accurate test for PE. It's nearly 100% specific and has a false negative rate less than 1%. However, there's actually a 0.5% mortality associated with the procedure, which is quite high if you consider the tens of thousands of tests a year that are needed to exclude a PE. Therefore, when testing for PE, pulmonary angiography is very rarely done. Here's an example of pulmonary angiography. As you can see, there's a severe filling defect in the left main pulmonary artery. The treatment of thromboembolic disease is basically just anticoagulation. Thinning the blood helps to treat the clot. You should begin with intravenous heparin. This is the best initial therapy, as you should answer on step 2. At the same time, you should initiate oral anticoagulant therapy with warfarin. This will allow you to achieve a therapeutic INR of 2 to 3 times the normal limit as quickly as possible. One question that often comes up on step 2 is, when is an inferior vena cava filter the right answer? There are really only a few situations. One is in the patient who cannot receive anticoagulants, such as one with melena or CNS bleeding. If the patient has had recurrent emboli while on heparin or fully therapeutic warfarin, they need an IVC filter to protect them. Lastly, a patient with RV dysfunction with signs of an enlarged RV on echo is also going to require an IVC filter. The reason here is that the next embolus, even if quite small, could be potentially fatal. Similarly, when are thrombolytics the right answer? Really, only in 2 situations. One, if the patient is hemodynamically unstable. By that, we mean the presence of hypotension and tachycardia. Similarly, if the patient has acute RV dysfunction, thrombolytics are indicated. These are contraindicated in a patient with recent surgery or recent bleeding. Remember, there is no specific time limit in which to use thrombolytics for PE like there is for stroke or acute MI. Lastly, when are direct-acting thrombin inhibitors the correct answer? These include argatroban or leparudin. These are the correct answer if the patient has a history of heparin-induced thrombocytopenia, or HIT. And when is aspirin the answer? Never. Remember, aspirin is not sufficient to treat a DVT or PE. You need full anticoagulation with either heparin, warfarin, or direct-acting thrombin inhibitor.